Yeah, thank you, Peter, for the kind introduction and also for the opportunity to speak here. Yes, there is a huge Philips banner. Yes, I'm with Philips, but I want to focus on really the approach and the technology and not so much on our products. Having said that, this presentation is maybe a bit of a strange duck in the pond. Philips is obviously not a pharma company, so I would love to focus on a bit of a slightly different approach. I've visited a few of the sessions this morning, and what I see is incredible innovations in pathology. Last week, I was at the RSNA conference in Chicago in the US, a radiology conference, amazing innovations in radiology as well. But what we hear from our clinical partners is that, yes, there is huge amounts of patient data and growing volumes of patients, but there's also a global shortage of radiologists, a global shortage of pathologists. And what we also see a lot is that diagnostic data, whether it's in radiology, whether it's in pathology, but also in other domains like cardiovascular, diagnostic data is gathered and managed, but also shared very asynchronously. And what we're doing, and that is maybe a bit of a reality check, what we're doing in innovations in radiology, innovations in pathology, we are adding more data. We are adding incredibly important insights in a certain disease. But there is also stakeholders in that care team of that patient who should make, let's say, sense out of that data. They should do the interpretation, and they should also decide, should that patient go left? Should that patient go right? Where should that patient go in that care pathway? And that we can also link to pharma. Should a certain patient be a candidate to a very incredibly important but also expensive immunotherapy? Yes or no? And what is that volume of data really causing? And that's what we see here. And these are some numbers I found, that 77% of healthcare professionals are losing significant time while looking for data, or actually facing that patient charts are incomplete and they don't have access to some of the data. And that is where we see that on average, a diagnostic or a treating physician is spending just over 4 hours per week looking for lost data and incomplete data. Yes, this is a fantastic event focusing on pathology, and this is a rather empty slide, and the next slide will explain the picture a bit. I'm showing this slide because the pathology, in this case, more and more digital pathology scanning, the pathology interpretation, either by a pathologist or AI enabled, is somewhere at the center, but there is so much in the care journey before a pathologist actually receives that sample. There is so much happening after the pathologist submits that pathology report into the laboratory information system or into the electronic medical record. And that's what I try to depict in the next slide. That's what we see here. This is a prostate cancer care pathway. It starts with MR imaging, radiology reading, image-guided biopsies, if the patient is lucky, then the pathology, and then all the data is being integrated. The data from radiology, the data from pathology, but also more and more the data from biomarkers or genomic markers as well. Then the patient is submitted to a treatment. I focused here on two treatments, radiation oncology and focal treatment, but this could also say systemic treatments, for example, in the case of lung cancer, if we're looking into lung cancer and not so much into prostate cancer, and then into the follow-up. And I'm showing this slide because what we hear from our clinical partners again is there is so much data gathered on that care journey, multiple sets of imaging, a biopsy, maybe a resection specimen, and all the data is if already all done within one hospital, the data is stored in multiple locations. And that is where I took a picture from one of our clinical partners, literally, I think a few months ago. So the next slide is not, it's maybe a bit provocative, but it's not a very old-fashioned slide of like years ago. It's a picture I took a few months ago, because all the data we are producing in radiology, all the data we're producing in pathology, with the cool innovations we're discussing in quite a few of the sessions here today and tomorrow, how is the data actually being used by that person who is maybe taking the data and helping that patient? And that's what I try to show on this slide. So what you see on the right-hand side is a very expensive, intuitive Da Vinci surgical robot. And in that red circle, just next to the shoes of the surgeon, in this case, a urologist, a surgeon, is a piece of paper. And on the left side, I zoomed in a bit and I took a close picture of what was actually on that piece of paper. And what you see is a representation of the prostate, of the organ. And then that urologist, in this case, had a look into the radiology report, had a look into the pathology report, and that urologist took that piece of paper, scribbled down, where did I see a lesion? Where did the radiologist see a lesion in the prostate? Where did we actually take the biopsies? What did the pathologist conclude on these biopsies? What is the Gleason grade group? How many millimeters of cancer? What that biopsy, maybe one of the biopsies was benign. And that is what you see on the left-hand side. And what we saw then in reality is that that surgeon was operating on a Da Vinci surgical robot. But during this surgery, the surgeon looked up 5 or 6 times from the device. So the moment the surgeon looks up from the device locks. The surgeon was looking at the piece of paper as a kind of landmark, Google Maps. Moving back into the surgical cockpit of this Da Vinci surgical robot, has to unlock and continue with the surgery. And this is just to show, yes, we are really adding a lot of information. We are finding so much more insights about that disease in radiology, but also in pathology, genomics. But the data is overwhelming to the person who's actually using a lot of that data. Again, disclaimer, on the next slide, you will see maybe some pictures of Philips products, but I do not want to push any of the products. It's really about the technology and the approach, please. So it starts, and this is really starts as a bit of a sequence. MR imaging, how MR imaging feeds into the next person in line doing a much better job than with an image-guided biopsy. And then how does that biopsy add up to a more accurate diagnosis together with pathology? So what we see here on the left-hand side are MR images of a prostate cancer patient. And what we see on the right-hand side is AI. And it's not Philips AI, it's AI actually from a third party called Tribim. They do the analysis on the MR images. And the radiologist sees some kind of heat map on the MR images where within the prostate is a certain suspicious area found. That AI app automatically puts that on a certain mapping of the prostate according to the so-called PIRAT score, which you see on the very right-hand side. And it automatically highlights in which zones or which segments of the prostate did the AI, and also confirmed by the radiologist, where in the prostate is a certain suspicious area found. That information is now more and more generated by AI, and then of course signed off by the radiologist. As the previous speaker said, the pathologist should also always confirm, and the pathologist is in the driving seat. The same applies for AI in radiology as well. What we see is that when you compare inter and intra-observer variability, the more and more we add AI to the MR reading, the more we can decrease the inter and intra-observer variability in radiology as well. But it's not so much about only generating that radiology report. It's also how that data is being used by the next person in line. How can we make sure that that information from radiology is used by the urologist to do a much better job positioning that needle inside the prostate? Because that needle with that piece of tissue, that actually ends up at a glass slide, and that ends up for you in pathology. So what we see here on the right-hand side, and I will start a short video in a second. You see the ultrasound images which are done during the biopsy procedure. And what we more and more see is that technologies are being used that you take the MR images which are done in diagnostics, the ultrasound images which are used during the biopsy procedure, and we fuse live during the biopsy procedure, we fuse the ultrasound and the MR images, and then we follow the tip of the biopsy needle to make sure that that tip of the biopsy needle ends up where the radiologist on the previous slide did say in these segments of the prostate a suspicious area has been found. I will start the video, and then you will see actually the MR and the ultrasound overlay, and then you see that we follow the tip of the needle in such a way that tip of the biopsy needle ends up in the place where the radiologist identified that suspicious area. So that's what you see happening now. You see we're moving from MR to ultrasound and back. The urologist in this case can position. Radiology did see what you see here. In red, the outline of the prostate, in green, the outline of the suspicious area or the tumor. And then that purplish pink dot, that is where the biopsy procedure should really happen. And now you see the biopsy needle moving in, and the biopsy is really collected from that area where the radiologist did find a suspicious area. What we see is that instead of doing more systematic biopsies, shooting more or less randomly 10, 12, or 14 biopsy cores into the prostate, depending on the size and the volume of the prostate, we can significantly reduce the number of biopsies from 10, 12, 14 biopsies down to 3 or 4 biopsies, while improving the cancer detection rates for clinically significant prostate cancer by 30%. If we link that to the first slide I presented, where I mentioned the global shortage of pathologists, keep in mind that if we go from 12 biopsy needles to back to 3 biopsy needles, that's significantly less unnecessary work for pathology. Because out of the 12 biopsy needles, a lot of them are negative, which means there is no prostate cancer, because you more or less randomly puncture the prostate, hoping to find the tumor. So there is more positive biopsies and less unnecessary work for pathology to look into negative biopsies as well. And then if we take the next step, that's where I want to be really brief on. This you all know. Maybe you have seen some of the exhibitions upstairs where we actually see the IMS, the image management system. And yes, there are a lot of really cool AI vendors above, also showing their really cool innovations in AI. What I'm showing here is a short video capture of the image management system, but also how we start applying AI in that as well. But I think that's more known to you than it is actually to me. So I'll start the video, and what you see that we start applying AI in pathology as well. And this is not Philips AI, but it's actually the AI algorithm from our friends from IBEX, the IBEX prostate cancer algorithm. Proof points that going from analog microscope-based pathology up to digital pathology, efficiency and productivity gains 15 to 20%. Adding AI to digital pathology, we see efficiency gains from microscope to digital pathology with AI up to 37%, which means we can help you in pathology to do a much faster job coming to an interpretation of the images. But you can also really submit a pathology report much faster, and that makes sure that you get to a diagnosis faster. The moment you come to a diagnosis faster, you can start a treatment faster as well. So we have seen MR imaging, we have seen the image-guided biopsy and the digital pathology. But it's really also about the approach of integrating that multi-ology data. And that is what I summarized here. And we call that integrated diagnostics. So what you see on the left-hand side is the MR images with the AI, and then the digital pathology with or without the AI. And then on the right-hand side, you see an outline in red, an outline of the prostate, in green, an outline of the lesion within the prostate, and then 2 of the biopsies inside that lesion, which are also color coding. And that color coding is done according to the Gleason score or Gleason grade group. And what we're now doing as a next step, and again, that's why I said maybe a bit of a strange dog in the pond. It's not so much to pharma yet. We are now first applying that data and use that data and make that data available in a more structured way to show this to the surgeon. I've shown that piece of paper with the handwritten note before. And what you see here on the right-hand side now is that within that surgical robot, we are taking in this case, it was still a 2D model. We're now moving towards a 3D model, which you see here. That surgeon or that urologist can actually see the information. Where did radiologists see a suspicious area in the prostate? Where did we exactly take the biopsies? What was the pathologist's conclusion on analyzing the biopsies? And how can we use that data in a meaningful way to decide what should happen next? Where does that surgeon needs to be more radical, take away more tissue with the surgery, and maybe on one side be less radical? Keep in mind, maybe getting a bit more clinical, around the prostate, there are 2 neurovascular bundles. If you cut both of the neurovascular bundles, that has a huge impact on the quality of life of that prostate cancer patient using urinary and erectile function. And so we're more and more using data. What did radiologists see? Where did we take the biopsy? What was confirmed by the pathologist? Is this malignant, yes or no? To guide that surgeon where to take away more tissue and be more radical, make sure that you don't have any positive surgical margins. Where can we be less invasive in the surgery? Where can we actually spare the tissue? That was the approach literally until a few weeks ago, and we are now also taking the same approach with the image-guided biopsies towards image-guided focal treatments. And then if we have such an image, then within that part of the prostate where we have a confirmed lesion, we will bring in the same needle, and we will use energy sources, laser ablation, cryoablation to really treat the tumor there where the highest Gleason grade group was seen. In other areas where there was a benign biopsy found, obviously no harsh treatment is needed. So we're moving away from image-guided biopsies towards image-guided focal treatment as well. Yeah, this is really in a nutshell. I think with that, we're done a bit earlier, but that's not a bad idea before lunch, I guess. Let me wrap up here. Right.